Either injury or infection can lead to a series of signaling pathways getting stimulated. Injury leads to the formation of a damage-associated molecular pattern (DAMP), and infection leads to the formation of a pathogen-associated molecular pattern or PAMP. Both of these use signaling pathways to mobilize the inflammatory process. A minor host insult results in a localized inflammatory response that is transient and beneficial. But in the likely event of a major host insult, all these reactions are now amplified, leading to systemic inflammation, remote organ damage, and multiple organ failure. It has been seen by the studies that the people who die from their injuries are different from the survivors only in terms of the degree and the duration of their inflammatory response. So one can understand that a small inflammatory response is very beneficial, but if it goes unbridled, it is actually counterproductive. The spectrum that is displayed here in the form of a table is SIRS, sepsis, severe sepsis, and septic shock. It is very common to see these kind of patients in the ICU, and initially it was believed that all cases of SIRS are caused because of infection. Although the research tried to find a microbial etiology for the SIRS, in trauma it is seen that SIRS is sterile. As one knows that this SIRS can originate from two kinds of stimuli, either the PAMP or the DAMP, also known as an alarmin. One should keep in mind that in cases of trauma, pancreatitis, head injury, myocardial infarction, lung injury, multiple fractures, there is going to be sepsis without infection, or else SIRS without any evidence of infection. So one should keep in mind that not every case of SIRS originates because of a microbiological insult. The human beings have two kinds of immunities: the acquired immunity and the innate immunity. The innate immunity doesn't require any kind of weird stimulation, such as being presented with an antigen and later reactivating this whole process in a better fashion. The innate immunity gets activated as soon as there is something foreign in the system. Now once the DAMPs come outside the cell, they promote the activation of the innate immune cells. At the same time, they even recruit the activation of the antigen presenting cells. Therefore, the host defense systems are now activated. This table presents different DAMPs, and we shall touch upon them in the coming slides. HMGB1 is a protein which can be taken as a prototype of the DAMPs. Within 30 minutes of trauma, HMGB1 is released into the circulation. HMGB1 can also be released from the circulation if there are PAMPs which have affected the human being. At the same time, an inflammasome, or a huge collection of inflamed cells, can also release HMGB1. In the likely event of cell death, or sometimes when there is a programmed cell death, HMGB1 can be released. Once the HMGB1 is outside the cell, it reacts with various receptors, toll-like receptors, the TLRs, and the receptor for advanced glycosylated end products, RAGE. The activation of these receptors will further create certain signals which will release cytokines and chemokines from the macrophages. It activates the neutrophils and causes chemotaxis, and at the same time it changes or alters the epithelial barrier function. Thus it increases permeability. In addition to all this, it increases the procoagulant activity of platelets. Therefore, to get a bigger picture, coagulation takes place easily. The epithelial cells of the capillaries are more permeable so that there is easy leaking. There is activation of neutrophils. At the same time, there is activation of macrophages. So you're getting some kind of a DIC picture here which somehow mediates the sickness behavior. Now it has been shown that if HMGB1 levels in normal subjects increase unchecked, it promotes a self-injurious immune response. And in the likely event that a normal animal has been injected with HMGB1, it produces fever, weight loss, loss of the epithelial barrier function, and at times even death. One understands that the powerhouse of the cell is the mitochondria. It is needed for oxidative respiration. But in the likely event of cell death and mitochondrial damage, certain mitochondrial proteins and sometimes even DNA can act as a DAMP. It triggers the inflammatory response, leading to necrosis and cellular stress. It has been shown by studies that these mitochondrial products are 1,000 times higher in both trauma patients and those going femoral fracture repair. And in the likely event that these mitochondrial proteins were injected into animal models, it led to remote organ damage, liver and lung inflammation. Studies have shown that these mitochondrial proteins are capable of forming certain peptides which induce an inflammatory response in neutrophils by increasing chemotaxis, oxidative burst, and cytokine secretion, which further causes signaling to increase the inflammation. Quite recently, it has been shown that the extracellular matrix, which consists of proteoglycans, glycosaminoglycans, and glycoproteins, example fibronectin, when these extracellular matrix proteins have been broken down, they go and react with the TLR, which is the toll-like receptor. And you can remember that the toll-like receptor used to react with HMGB1. Now when the ECM proteins react with the toll-like receptor, they also stimulate the inflammasomes and they can trigger the sterile inflammatory reaction, leading to signaling pathways which promotes the inflammatory process exponentially. Thus the ECM matrix proteins also can act as a DAMP. So far we have understood that there are either DAMPs or PAMPs which can stimulate the inflammatory process. Let us imagine the DAMP or the PAMP to be like a key. Now this key, when it fits the lock, will open up a wide variety of signaling compounds. As far as the lock is concerned, these locks are called pattern recognition receptors. They recognize a certain pattern. Now the class of receptors which are important for sensing damaged cells or cell debris can even sense pathogens. And there are four distinct classes of the PRRs. First is the toll-like receptor, the TLR, the calcium dependent lectin receptor, better known as CLR, RLR, which is retinoic acid inducible gene like receptor, and finally NLR, a big name, nucleotide binding domain leucine rich repeat receptor. I think we'll stick to the short forms for now because there is no fun singing big songs with these kind of words. The TLR is a transmembrane protein and it can recognize lipid, carbohydrate, peptide and nucleic acid components. The TLR consists of two parts: an extracellular domain which has multiple leucine rich sites and an intracellular domain which has a carboxy site, a C double bond O site. The NLR receptor is present inside the cytoplasm and it can get stimulated by both DAMPs and PAMPs. A dead or a dying cell, or even a cell which has been attacked by a T cell, releases certain molecules which are easily recognized by the macrophages and the dendritic cells. These activate the macrophages and dendritic cells, and the receptors which direct this process are the CLR family. So far, we have understood the key and the lock hypothesis. To add to the confusion, there is another molecule which is called the soluble pattern recognition molecule, and the prototype here is the pentaxtrin. Now, in the likely event of there being any inflammation triggered by either a DAMP or a PAMP, there are certain molecules which come out which are called the soluble pattern recognition molecules. Ultimately, they will lead to complement activation, agglutination, neutralization of the bacterium, and even opsonization. Opsonization happens to be like putting a lipstick on a picture. It increases the attractiveness of that certain molecule to the macrophages and the dendritic cells. Also, it helps for the T cells to get attracted to the opsonized molecule. Now, these pattern recognition molecules can be synthesized at the site of injury and inflammation. They are synthesized by macrophages and dendritic cells. In addition to which, neutrophils can even store these PRMs and can rapidly release them following their activation. C-reactive protein is one kind of a pentaxtrin. There are many other pentaxtrins also. These are called the acute phase protein response because let there be inflammation or infection anywhere, the moment the key and the lock hypothesis works, in a parallel process you have soluble pattern recognition molecules getting released, which will now amplify the inflammatory response which has been triggered either by a PAMP or DAMP. So if you have a loudspeaker kind of a system inside the body, it is because of the pentaxtrins. Now we look at the unlocking process. If the key and the lock get together, that is when the pattern recognition receptors start signaling from their side. As far as the toll-like receptor is concerned, once it gets activated, there are going to be many different kinases which come into action, breaking multiple proteins. But one of the universal adapters to the TLR happens to be the myeloid differentiation factor 88, which then recruits the cells of the myeloid stream to get activated, and in the end there are going to be a production of inflammatory cytokines and also many inflammatory cells getting recruited. As far as the signaling from the inflammasome is concerned, there is an activation and assembly of different cytokines. At the end there is a cleavage of procaspase, which then leads to interleukin 1 converting enzyme getting activated. This then goes on to activate a series of interleukins, which are potent pro-inflammatory cytokines, thereby recruiting inflammatory cells to the area of inflammation and then also leading to systemic inflammatory response syndrome. Till now we have realized how the inflammatory process gets initiated and how the signaling pathways can increase the response exponentially. There is also a regulation of the SIRS, which is done by the CNS, and as one is well aware, where the nerves cannot go, the chemicals go. So there is a very strong neuroendocrine response which regulates the SIRS. This diagrammatic representation shows the coordination and connection of the CNS with the soma. In the likely event of any inflammation or injury and release of cytokines, the inflammatory cascade even stimulates the nervous system. Sensory signals go to the CNS and there is an immediate neuroendocrine response, which we shall be seeing in detail. It has been shown that various cytokines which are released during innate immunity, such as by DAMPs or PMPs, or even during adaptive immunity release of cytokines, pain response, anxiety, angiotensin II, vasoactive intestinal polypeptide, or any molecule at the injury site can all contribute to the release of CRH. CRH then causes the release of ACTH, which then causes the release of cortisol from the adrenal. Now, various molecules like cytokines in pain and anxiety can even cause direct stimulation to the ACTH release. Now, cortisol exerts an anti-inflammatory action on this whole sequence. When cortisol binds to the glucocorticoid receptor, first of all it deactivates toll-like receptors. It also deactivates cytokines, adhesion molecules, and nitric oxide. The macrophage inhibitory factor can also modulate the cortisol action. The MIF directly counteracts the anti-inflammatory effect of glucocorticoids. It also increases the amount of TLRs which are seen in the macrophages. Now, when one compares the survivors and the dead people, the people who are non-survivors seem to have a higher level of MIF in their systems. Growth hormone promotes protein synthesis and insulin resistance. It also enhances the mobilization of fats. Insulin-like growth factor is an anabolic growth factor which can improve the metabolic rate and the gut mucosal function. In the liver, it stimulates protein synthesis and glycogenesis. In the fat tissue, it increases the glucose uptake and the fat utilization. In skeletal muscles, it improves glucose uptake and protein synthesis. It also increases the proliferation of the T cell population. During a severe catabolic state, which happens after injury, there is a suppression of the growth hormone and the insulin-like growth factor axis. And therefore, it has been shown that if burnt children have been given recombinant human growth hormone, both acutely and following the treatment, it is proven to be beneficial. Ghrelin is a natural ligand, or you can say it is a key for the growth hormone receptor. Ghrelin stimulates the appetite and it is secreted in the stomach. Ghrelin has a role in promoting growth hormone secretion, glucose homeostasis, lipid metabolism, and immune function. In certain animal models, ghrelin administration inhibits the pro-inflammatory cytokine release. It reduces neutrophil infiltration and it reduces the intestinal barrier dysfunction. And thus it's so interesting how ghrelin can actually reduce the inflammatory effects. The catecholamines are well known in the fright, flight, or fight response. They have many effects on the body, but as far as the inflammatory system is concerned, these are mainly pro-inflammatory. So during the inflammation, at the neuroendocrine response, the glucocorticoids will serve to dampen the inflammation. At the same time, there is going to be a hyperglycemia, increased amount of growth hormone, ghrelin, and insulin-like growth factor, which tends to dampen the inflammation. Whereas the catecholamines in the system seem to modulate the inflammation and seem to be a little pro-inflammatory. So there is a fine balance between increasing and decreasing the inflammation from the neuroendocrine response. Aldosterone, a potent mineralocorticoid, is known to have anti-inflammatory effects also. The metabolic response to trauma is a hyperglycemic state, and there is also insulin resistance. During the hyperglycemic state, there is a decrease in phagocytosis, chemotaxis, and adhesion. There is also a reduced respiratory burst. All of these contribute to the anti-inflammatory effects and increase the risk of infection.